Welcome to today's lecture on pharmacology, focusing on the management and treatment of Parkinson's disease. Parkinson's disease is a neurodegenerative disorder characterized by the progressive loss of dopamine-producing cells in the brain. It presents with motor symptoms such as tremors, rigidity, bradykinesia, and postural instability. Our discussion today will delve into various pharmacological interventions utilized to target these symptoms and improve the quality of life for patients. To understand the pharmacological treatments for Parkinson's disease, let's first explore the underlying mechanisms of this condition. Parkinson's disease is primarily caused by the degeneration of dopaminergic neurons in the substantia nigra, leading to a decrease in dopamine levels in the basal ganglia. This neurotransmitter deficiency disrupts the delicate balance between dopaminergic and cholinergic signaling, resulting in the characteristic motor symptoms observed in patients. In order to replace the deficient dopamine in Parkinson's disease, pharmacotherapy primarily revolves around the use of dopaminergic agents. These medications aim to either increase dopamine synthesis, enhance dopamine release, or stimulate dopamine receptors. Levodopa, the gold standard treatment, acts as a precursor to dopamine and is converted to dopamine in the brain. Other dopaminergic agents, such as dopamine agonists, directly stimulate dopamine receptors. Levodopa remains the most effective treatment for managing the motor symptoms of Parkinson's disease. When administered orally, levodopa is rapidly absorbed from the gastrointestinal tract and undergoes decarboxylation to dopamine in the brain. This conversion is catalyzed by the enzyme aromatic L-amino acid decarboxylase, AADC. However, long-term levodopa use is often associated with the development of motor complications, such as dyskinesias and motor fluctuations. Dopamine agonists are a class of medications that directly stimulate dopamine receptors in the brain. Unlike levodopa, dopamine agonists can be administered orally or transdermally. These agents include pramipexole, ropinirole, and rotigotine. By activating dopamine receptors, dopamine agonists mimic the actions of endogenous dopamine, alleviating the motor symptoms of Parkinson's disease without relying solely on levodopa metabolism. To optimize the efficacy of levodopa therapy, adjunctive pharmacotherapy with Catechol-O-Methyltransferase, COMT, inhibitors may be utilized. COMT inhibitors, such as entacapone and tolcapone, work by inhibiting the degradation of levodopa in the peripheral tissues. By prolonging levodopa's half-life, COMT inhibitors enhance its therapeutic effect and reduce off periods, thereby improving motor fluctuations and promoting a more stable response to medication. Monoamine oxidase-B, MAO-B, inhibitors, including selegiline and rasagiline, are another class of adjunctive medications used in the management of Parkinson's disease. MAO-B inhibitors selectively inhibit the enzyme MAO-B, which metabolizes dopamine in the presynaptic terminals. By inhibiting MAO-B, the breakdown of dopamine is reduced, leading to increased dopamine levels and improved motor symptoms. Anticholinergic agents, such as benztropine and trihexyphenidyl, may be employed to manage the tremor-dominant symptoms of Parkinson's disease. These agents exert their effects by blocking muscarinic acetylcholine receptors in the striatum, thereby rebalancing the disrupted cholinergic dopaminergic interplay. However, their use is limited by their potential for side effects, including cognitive impairment and dry mouth. In cases where patients develop dyskinesias as a complication of long-term levodopa therapy, N-methyl-D-aspartate, NMDA, receptor antagonists can be considered. Amantadine, a well-known NMDA receptor antagonist, is thought to exert its anti-dyskinetic effects by modulating glutamate neurotransmission, leading to a reduction in abnormal involuntary movements. In addition to pharmacotherapy, non-pharmacological interventions play a crucial role in managing Parkinson's disease. These interventions include physical therapy, occupational therapy, speech therapy, and exercise programs, which aim to improve mobility, maintain independence, and minimize the impact of motor symptoms on daily activities. Parkinson's disease is not solely limited to motor symptoms. Patients often experience a range of non-motor symptoms that require specific pharmacological interventions. These symptoms may include depression, anxiety, sleep disturbances, constipation, orthostatic hypotension, and urinary symptoms. Selective serotonin reuptake inhibitors, SSRIs, tricyclic antidepressants, TCAs, and other medications may be used to manage these non-motor symptoms. For patients who do not obtain satisfactory control of symptoms with pharmacological therapies alone, surgical interventions may be considered. Deep brain stimulation, DBS, is one such surgical approach, where electrodes are implanted in specific brain regions to modulate abnormal neural activity and provide symptomatic relief. Other surgical options include pallidotomy and thalamotomy, although these techniques are less commonly performed in modern practice. Apart from symptomatic management, efforts are underway to develop disease-modifying treatments that can slow down the progression of Parkinson's disease. Several drugs, such as rasagiline and safinamide, have shown potential in neuroprotection and possess properties that may halt or delay disease progression. However, further research is still required to establish their long-term efficacy and safety. In conclusion, the pharmacological management of Parkinson's disease is multifaceted, involving various classes of medications that target different aspects of the disease. Levodopa remains the gold standard treatment, and its effectiveness can be enhanced by adjunctive therapies such as dopamine agonists, COMT inhibitors, and MAO-B inhibitors. Non-pharmacological interventions, surgical options, and ongoing efforts to develop disease-modifying treatments also contribute to the comprehensive management of Parkinson's disease. As we continue to expand our understanding of the pathophysiology of this complex condition, it is essential to integrate these pharmacological approaches into individualized treatment plans for patients with Parkinson's disease.